Good evening, everybody. Good morning, good afternoon, wherever you are. It's my great pleasure to welcome you to this a new journal club by the International Academy for Clinical Hematology. I do apologize. We are a bit late, but unfortunately we were facing some technical issues. So this is our first journal club of the year 2021. According to the French tradition, it's still time to wish you a happy new year. All best wishes for a successful and healthy new year. And hopefully we will get rid very soon of this terrible COVID-19 pandemic. But in the meantime, our IACH activities continue thanks to your support. The Journal Club is supported by Takeda Oncology through an unrestricted educational grant. I'm not going to spend a lot of time explaining or highlighting the importance of such activities, the Journal Club, because the amount of scientific literature, especially in hematology, I'm not talking about COVID because here it's exponential actually, is growing, and we really need to have a critical analysis, evaluation of such data. So this is clearly the spirit of a journal club, where the idea is to summarize the data and ask some experts to put this into perspective and how all of this can or will impact our clinical practice. And for this journal club today, this is the paper that was chosen. You can see the title, Oral Azacitidine Maintenance Therapy for Acute Myeloid Leukemia in First Remission. And actually that was published, you can easily remember the date, on the 24th of December last year. And for the purpose of this journal club, the tradition is that we always welcome a co-author of the paper. And my guest today is Dr. Prof. Montesinos, who is a senior consultant in Valencia in Spain, and he is in charge of the leukemia program there. So thank you, Prof, for joining us tonight.
Thanks for the invitation. Thanks.
And the other faculty, and both of them are actually very good friends, is Dr. Thomas Prebet from Yale University in the US, who is also a top expert in the field of acute leukemia. And Thomas, I guess, is not a co-author on this paper, so you will play the role of the outside reviewer, Ed would say. But before going and asking you and going into through these questions, just a brief summary about, so I can see Professor Prebet. We can hear you, Thomas.
Okay, perfect. There was some lag on the internet, so my bad for that. But thanks for the introduction. Actually, it was great.
Excellent, thank you. So this is a problem, guys, when we are really broadcasting live. We didn't record anything because I think you are all used to many pre-recorded activities. We are always live. We love to be live. We love to be in the real life, guys. So you can see the summary of this trial. This is the abstract, and actually this was a phase 3 randomized double-blind placebo-controlled trial, so really very high level of design. And that was the oral formulation of azacitidine CC486, and that was used as a maintenance therapy in patients with acute myeloid leukemia who were in first complete remission after receiving an intensive induction chemotherapy. Patient had to be at least 55 years of age, and that was considered, and we'll discuss this, as a sort of an elderly patient. Newly diagnosed AML, intermediate poor risk cytogenetics, and of course, if they were candidate to be, if they were considered to be candidate for allogenic stem cell transplantation, so consolidation with allogenic stem cell transplantation, they were excluded. And this is another topic that we will discuss. And the definition of CR is summarized here, and the treatment actually was administered orally versus placebo. These were day 1 to day 14, repeated 28-day cycles, but there were also some guidelines for those patients who relapsed, but only with 5 to 15% blasts in the blood or bone marrow. And interestingly, that was a very hard endpoint, I would say, the one we are always looking for. Primary endpoint was overall survival from the time of randomization. And you can see these beautiful curves, the upper curve about the overall survival, looking at 24 months, for instance, and you can appreciate the highly significant difference between the blue curve, so this is the experimental arm, and the gray curve, which is the placebo arm. And when you look to the relapse-free survival, we do have a similar pattern. So with this summary, my first question is going to be to Dr. Montesinos, and this is going to be, I mean, very simple question. What is your first reaction, your input, and you participated to this trial? What's your take-home message to our audience about this trial?
The trial had very good design, so we can say nothing about this. It was a double-blinded, randomized. Is the design of the clinical trial that we want to see to get reliable results in good experimental conditions. So there is nothing to say. Hopefully, all trials nowadays leading to indication of new drugs had this design. No. Regarding the results, I think that this is opening the door for further exploration of maintenance schedules in AML. This was something that was forgotten in the past, because several attempts, one of them of the French group, for example, using maintenance with semi-intensive chemotherapy in older patients. But this trial has clearly positive results. The primary endpoint was met. There was an overall survival improvement, I would say clinically relevant overall survival, almost doubling the survival of patients. Also regarding the relapse free. So this is the first impression, in my opinion, that the message that we need to take home from this clinical trial.
No, it's a clear message. Thank you, Pau. And before going to Dr. Prebet, I would also kindly remind all of you who are watching us that you can submit your questions using the chat. You can also just make comments. You can agree, disagree, and I'll do my best to bring your questions or your comments to our faculty. So, Thomas, what is your take-home message when you've seen this paper?
First, I was pretty happy to see that the epigenetic maintenance was improving the outcome for this patient. As mentioned by Pau, we had many attempts to basically include maintenance in acute myeloid leukemia for patients that were not eligible for transplant, and to say the least, that has not been really successful. There was the IL-2 agonist a few years ago that was basically approved, but never really made any impact on the market because of the side effect. I think that this basically study is really a landmark study showing the importance of maintenance in this population. I think that semantics are also extremely important. We're talking about maintenance. We're not talking about consolidation, and that's, I think, something we need to stress to the audience, that the study has really been designed with investigators looking for a maintenance, and that's not going to replace, for example, intensive consolidation maintenance when patients are eligible for. That can be a subject of debate on how many cycles basically should be warranted. But I think it's important to stress that the objective is really maintenance and not consolidation in the majority of the patients.
Excellent. So and we have already actually a lot of questions. It looks like that this article is generating a lot of interest, and I can guess why. You know, having a sort of an easy to use, safe oral agent in AML when all previous trials of maintenance have failed, well, that's really good news. So let's dig a little bit deeper into the design of the study, Pau. So we have one question, and I have made the same remark, that we consider elderly AML in this trial starting from age 55, which is a bit unusual. Usually it's at least 60 or even 65, and we know that ages keep on increasing. So that's one point. Any comment on this threshold of age 55?
Personal experience in this trial, we have included, I remind, about 25 patients. So it is not a small experience. And in fact, the majority of patients that were included in the trial, they were really patients suffering from toxicity during induction and consolidation, patients that were really not eligible for allogenic transplant. They were patients that really, sorry, because I have some background noise. They were patients not eligible for transplant, with not good tolerability to prior chemotherapy. So patients with, in my opinion, an incomplete frontline approach. So patients that really we all will bet that they are not cured with the induction and first or second or even third consolidation cycle. So I think that this trial was focusing really in patients that are not receiving the optimal frontline approach with induction and consolidation cycles, and of course no intensification with an allogenic stem cell transplant. So we need to keep very focused on which was the target population of this trial.
So that brings me to the
Mohamad,
question.
can I comment on that?
Yes, please.
No, I think you're definitely bringing a really important point, because the question we should ask now is, in 2021, what proportion of my patients would be really eligible for such a treatment? And I think it's important to stress that with the basically improvement we've done with transplant, for example, with the number of patients we can now treat with haploidentical transplant, and with the fact that some of the elderly population, and you can have different threshold on that, will go now more on an azacitidine-based treatment. Potentially, the number of patients that might be eligible for maintenance may be really limited, as you were mentioning, to this 55 to 70 years old patient that are not doing well initially. And looking at what we are doing, that's maybe not going to be a high proportion of our patients.
So can I follow up, because we have a few questions on this transplant issue, because the protocol, the trial, did not specify any criteria with transplant eligibility. Can we consider this as an acceptable approach? Pau?
It's difficult to say because, of course, you can design a trial in the front line with non-intensive approaches for unfit patients, and you need clearly to define which patient is eligible for intensive chemotherapy and what patient is not eligible. I think that we need to keep in mind that this trial started on 2012 and get more than 5 years in a multinational, run a lot of sites to enroll the sample size, which was a big sample size. So you may imagine that the original design of the trial was made on 2010 or 2011, no more. So I think that things change a lot, not only regarding the best approach to these borderline patients, which were enrolled in this trial, but also regarding the regulatory approach to the clinical trial design.
Thomas, what is your thought on this? No, I completely agree. The whole landscape of treatment in AML has completely changed between 2017 and now. So it's definitely true that when you are trying to basically get this data in our clinical practice, it's a completely different landscape between the targeted therapies, between basically as I was mentioning, the progress in a transplant, Azaven, that's a completely different landscape. Nevertheless, I definitely see that we have a proportion of patients that will benefit from such a treatment. And that's also a stepping stone for us to be able to start to play with the drug. There's right now a lot of different things going on. I don't know if we'll have the time to go on that, but there's a lot of options we have and a lot of potential design that can be considered with this drug. That can be fun to do.
Okay, excellent. I think this is clarifying a lot of things, and thank you for this perspective. We have also a lot of questions, and it looks like our audience have read really nicely the paper about the cytogenetics. So the paper relied exclusively on the conventional cytogenetics. However, we know that in 2021, we're relying more and more on molecular markers, NGS. So how would you reconcile this, and how would we apply these results today in view of the molecular markers? For instance, I would guess that some of these patients were FLT3 ITD, and you may wish, and we have a few comments about this, to give them FLT3 inhibitors maintenance instead of this oral AZA. So what are your thoughts, guys, on this?
I may start if you want, Spo. I would say that's definitely one of the biggest question. If you remember the RATIFY study with midostaurin, I think it's important to remember that the maintenance was definitely an integral part of the study, but the study was not powered to show any real benefit or difference of the maintenance. So I think that a lot of us are considering the maintenance for the patient that do not go for transplantation, but the level of evidence of the benefit of transplantation with the midostaurin, it's basically not that much as compared to basically what we have here with a well-designed randomized study. I definitely think that what we need to see, and I guess that's going to come probably for IHA, that's going to be some details on the molecular subtypes. Paul, you probably know better than me because I'm not part of the group on this one, but probably some more details on the genomics and the impact on genomics on the outcome. But I think that's definitely one data that is extremely important to see.
Pau?
Can't hear you.
So we can't hear you, Pau.
I agree that in the new landscape of potential availability of targeted therapies, now it's only midostaurin, but yes, of course, what do you do with those patients? I think that naturally, if we have a midostaurin available for maintenance, we will keep on midostaurin because this was the trial of the design of the ratified trial. I think that the lack of more accurate genetic markers in the trial has also another implication, is that in this trial, patients with favorable cytogenetics were excluded. So this was a core-binding factor leukemia, by the way, at that time. But we have now the so-called low intermediate risk patients is NPM1 positive without FLT3 mutation. Some can say low allelic ratio FLT3 or CBP alpha leukemia. These are in fact more favorable risk patients, and just say that they were included in the trial, but we don't know, for example, in this subset of patients with NPM1 or CBP alpha, if the drug the maintenance schedule can give more benefit, for example, than in a monosomy 7 or a secondary AML. We don't have this information.
Can I go a little bit further in the results now and in the treatment schema? So when I read well this work, actually all the patients, and that was an inclusion criteria, received cytarabine and anthracycline. So classical, let's say 3+7 or something similar. 80% received at least one course of consolidation, but only 31% received 2 consolidation. So in another word, and we have a few questions about this. First of all, if we have given 2 consolidations to everybody, do we really need maintenance? And would this have changed the results? Also, we have a couple of questions about MRD. Assuming we can achieve MRD negativity after consolidation, do we still need maintenance therapy? So I think our audience is making it really trying to refine more and more the design of this trial if we have to do it again. So Thomas, what's your what do you think?
For the question about the number of consolidation and the impact of the number of consolidation, I would offer the audience to look at the late-breaking abstract that was submitted at the last ASH meeting, where basically there the relapse-free and overall survival Kaplan-Meier evaluation in the subgroup of patients that received no consolidation, 1 consolidation, 2+ consolidation. And it seemed that the benefit that we see from the maintenance is pretty consistent in the different subgroup. Basically, I added just in front of me, for patients that received 2 or more consolidation, the median survival was 28.6 months for CC for 86, and 17.6 months for placebo, for example. That's not statistically significant from just the p-value standpoint, because the numbers, the study was definitely not powered to allow to have this type of consolidation. But I think that there's still a benefit. When it comes to the MRD question, that's also a really good one. There's 2 things to know about that. One, there's some benefit for patients that were both MRD positive and MRD negative, provided that it was assessed, as far as I know, by flow cytometry, not by NGS, not by PCR for the NPM1 mutated patient. So there was some benefit in the different subgroup. And interestingly, there's also data showing that patient that starts basically the maintenance with oral AZA with a positive MRD, there's, if I remember well on top of my head, probably 30% of them that will improve their MRD status on treatment.
Pau?
I think that both aspects are the critical point of this investigation. And in my opinion, yes, of course, as Thomas say, the benefit is kept across all the subgroups, patients with MRD positive, MRD negative, 1 consolidation, 2 consolidation, but the trend is always the same. So patients that have been more efficaciously treated in the front line, so those with MRD negativity, those with 3 cycles of consolidation, those who get the more complete front line are benefiting less from the maintenance. And this is something not new. We know this, for example, I can give examples of acute promyelocytic leukemia, which was the first acute myeloid leukemia who showed some benefit from maintenance. When we improve the frontline approach in APL, we see less benefit from the maintenance schedule because patients are more efficaciously treated on the forefront. So now with arsenic trioxide and DATRA, there is no role of maintenance, and it was no role when the risk-adapted strategies with ATRA and idarubicin were implemented. So this was our perception, and I think that this is indirectly confirming these findings in MAL. I can give you another example. For example, the trial of the OVON group with subcutaneous azacitidine. Okay, this trial was performed in older patients more than 60 years old, and they were only eligible after 3 cycles, as I remind, of chemotherapy. So they were treated in the front line in a complete way through the OVON trial. And in this trial, they showed a benefit in the terms of relapse-free survival, but they were not able to show benefit in overall survival, and the curves were joining at the end of the observation period. It is true that this trial was designed with only 150 patients per, or 75 patients, I think, per arm. So it's totally, but it's always in the same line. So if you cure patient with a front line, you don't need maintenance. The question is that we don't have the data to know which patient will benefit from maintenance. And of course, MRD can be a good biomarker to lead us to take this decision.
So
another aspect to consider is from the design perspective, we need to remember there's a lead time bias in the way that things are basically presented, as the overall survival and relapse-free survival come from the time of randomization, which means that the patient that already had 2 consolidation already 3 months in remission. So that's something to take into consideration in the numbers that we are seeing. That's not time from complete remission, that's time from randomization.
Yeah, but I think we all agree that the good news is that within this trial, all the sub-analysis, the subgroups, and we can see this in figure number 3 of the article, are going into the same direction, which is quite reassuring, I think. So here, I want to speak a little bit about the trial, the way relapse has been handled, because the guidance in this trial was that if during therapy patient experienced 5 to 15% of blast, so not the traditional 20%, actually they had their regimen being enhanced. So having, instead of 14 days, going to 21 days. What do you think about this approach? I mean, for me, if I see a patient with 15% of blast, for me, it's a relapse. And I mean, if they are fit, I will go for another induction or for a different approach. What are your thoughts on this?
No, I think that this approach was acceptable for many patients included in this trial, because they were not really fit to go for another intensive schedule and an allogenic transplant with a curative approach. So keep the patient in trial with doubling the dose of oral azacitidine was acceptable, and the results show that, and this is an ASH abstract that was presented, show that many patients, or I think it's a 15% of patients around, can achieve a second complete remission after increasing the dose of oral azacitidine. The question also is that I think that 4 or 5% of patients in the placebo arm also reach a new complete remission after doubling the dose of placebo, no?
So placebo works.
Yes.
No, I think that's definitely interesting, and it's really for me interesting from the mechanistic standpoint. It's not something that you would expect from a classical Vidasa, for example, 7 days. You can discuss, for example, the interest of prolonged cycle of azacitidine. There's the data on decitabine 10 days, the data on 15 days of AZA from the GFM, for example. But this oral azacitidine is not working like the conventional HMAs that we have, the AZA, the decitabine, and I will include in this group also the oral decitabine. So that's for me one of the most interesting aspect of this aspect, the fact that we can potentially change this patient, and just by prolonging the hypomethylating age, demethylation, potentially improving the response. That's pretty interesting for sure.
So it's the pressure of hypomethylation, which is probably more feasible with an oral drug, and I think you have nicely emphasized, and I should have done this earlier, that this drug CC486 is not bioequivalent to subcute azacitidine. So that's very clear. And that brings me actually, guys, to the way we will handle and use this drug. So we have a few questions about the duration of maintenance. Is it going to be until progression, or do we at this stage have some any clue that it should be 1 year, 2 years, 3 years, or until progression? What are your thoughts? I know there's no answer for this at the moment, I think.
I mean, the design of the trial, if I remember well, was not basically limited in time regarding the number of cycles. And I remember discussing with Gail Robos, for example, mentioning a patient that is cycle 40, 45 of treatment. So that's definitely a good question. I mean, that can be just a guesstimate that we're going to get on how much time we can get this patient on a trial. I would say that it's a question that is important. At the same time, when you're looking at the data of on the long run, even with maintenance, we are still basically in a situation where 80% of these patients will progress at one point or the other. At 5 years, if you're looking at the percentage, that's still basically less than 20% of the patients that are doing well. So for the moment, I think that we should plan to give this patient probably until disease progression or toxicity. Prof, I mean, tell me if you think differently on that. The quality of life data that has been showed and the tolerability from the side effect standpoint seems to be pretty manageable, and there was no significant difference in quality of life for patients on placebo or on active maintenance with the oral AZA, which is somewhat reassuring. It's not telling us that someone without anything, placebo or oral AZA, will not do better from a quality of life standpoint, but at least it seems to be feasible, manageable, and acceptable for the patients.
So this will be the point in the next years with this drug. First, we need to see at the shape of the curves regarding especially relapse-free survival, and we can see that after 4 years approximately, the experimental and the control arm, they join. So the question is, after 4 years, we don't know, but do you believe that the patient who has not relapsed is not cured? I think that probably the patient.
But can I remind you that in the paper, the median follow-up is 41.2 months, which I think is a very decent follow-up when it comes to a so-called elderly AML. So I personally don't see a big issue with the fact that the results are maybe early or premature. Obviously, the question is, how can we do better? Maybe, and maybe this is where...
In my opinion, better is that you can withdraw therapy appropriately to the patient. So I can tell you my experience with patients that are still on therapy after 4 or 5 years, taking every 14 days oral azacitidine, and they are, and we are also afraid to withdraw the drug, because in fact this patient is alive and is probably cured or keeping his leukemia controlled through the drug. So it is difficult to withdraw the drug. I can tell you that some adverse events, late adverse events, for example, one patient now that experienced some COVID pneumonia, and the patient was well at the time of COVID pneumonia with good quality of life. And finally, after 3-4 months, we were not able to restart the schedule. So we definitely withdraw. Or, for example, I can tell you another patient that is a core-binding factor leukemia, an NPM1 leukemia. This is a good prognosis, and we can monitor through PCR, RT-PCR. And the patient after 4 years is a negative MRD. So the patient withdraw therapy. And the question is how long to keep the therapy. We don't know.
So just to be fair, regarding side effects and adverse events, I believe they were relatively okay, I would say, acceptable. So we have 43% in the paper reported interruption with the study drug. So for some adverse event, you have 43% of the patient who needed to interrupt, and you have 13% discontinuation. So obviously that fits with our understanding about using novel drugs in this population. So I think it's a good safety profile. So we have here a more philosophical question, I would say. Why, and maybe Thomas, you started alluding to this about the intensity or the pressure of hypomethylation, because if I remember well, the AML 16 UK trial, from the MRC, could not show an overall survival benefit if using 5-AZA subcute, the traditional popular one, not the oral one. Whereas with the oral one, we see an overall survival advantage. So how can you explain this?
I don't think we have any definitive explanation. The main hypothesis, as I was mentioning, is the oral AZA is a different beast as compared to our standard hypomethylating agent. It has not been designed to be a perfect equivalent of the AZA. Initially, yes, because the first study, for example, published by Guillermo Garcia-Manero, that was this kind of bioequivalence study. But since then, since basically this first study, they moved on from this short schedule to a more prolonged schedule, allowing a more prolonged impact on the methylome. Can I tell you that it's clearly a methylation effect? No, because we are still basically 20 years in using hypomethylating agent, and we don't have a biomarker that we can use easily to prove that the hypomethylating impact is really what's making the difference. But I think that for the audience, it's really important to know that we definitely have a different safety profile. We definitely have a different impact on the clones, on the leukemic clone, than what we have the hypomethylating agent. And you're not in a situation where you can just potentially switch from the oral to the IV, even if it's extremely tempting, for example, in a lot of patients.
No, I think that apart from pharmacodynamic properties that could differ. Of course, we don't know. I think that the hypomethylation is a black box by the end. I think that the tolerability is critical for the success of oral azacitidine in comparison with subcutaneous schedules. I think that we cannot extrapolate because, as we mentioned, a patient can be 1, 2, 3, 4 years under therapy, and it is not at all the same to take a pill. And in my experience, it was not easy to distinguish which patient was in the experimental arm and which patient was under placebo. And this is the main point to know that the drug is tolerable and has a good safety profile. I think that this is critical for the success of this schedule. Of course, some patients had some even grade 3/4 neutropenia that was well managed with drug holidays and dose adjustment. Some of them, they had a nausea, but was manageable. But beyond the pharmacodynamics and anti-leukemic properties, tolerability is critical.
Okay, so we have a question which is just immediate popped in like 1 minute ago, 1 second ago, from Dr. Jose Luis Lopez Lorenzo, saying, well, okay, they are not equal or bioequivalent, but assuming you have both of them available, would you choose one and use it, or you still need, you know, the 2 compounds, the subcute 5-AZA and the oral? Thomas.
I would say for the moment we don't have data, for example, in MDS showing us that it's equivalent. I mean, that's the other way around. When you're looking at, for example, the low-risk study that was done a few years ago and presented by Valeria Santini and other, where this oral AZA was not able to make the cut to show a benefit. So for the moment, the only data that we have is that this oral azacitidine is basically good for maintenance in AML. So my wish, basically for next Christmas, we had the paper last Christmas, basically, that my wish for next Christmas is to start seeing more data on combinations, for example, and more studies basically starting on combinations. More studies showing what this drug can do in the transplant setting also. There's some data from DeLima, for example, on the use of oral AZA post-allo, and I think it's pretty exciting. So I want to see more of this. Once again, there's a lot of possibility that we can consider, a lot of different investigation we can consider with this drug, provided that we should really move away from the idea that it's just a bioequivalent.
Okay, so time is running, guys. So I'll take a sort one last question, and unfortunately, I can't read the name of the colleague because it is in a Russian alphabet, I think. But thank you for raising this important question. Is about the future. I mean, in this paper, we were relying almost exclusively on a 3+7 or similar induction regimen, but we are using more and more things like venetoclax and 5-AZA, especially, you know, in these frail or unfit patient or elderly patient. So how do you see the future of oral AZA when you look into this doublet combination of subcute AZA plus venetoclax? Is it going to be like we keep on this doublet and then we give the oral maintenance, or we do trials? So can you guide us for the future, maybe?
Definitely a question for clinical trials, knowing that it's definitely questions that are currently on the table. That's a question of equipoise in what we are doing. And I think that depending on the center, depending on the investigators, that's going to be a hard sell to basically downgrade the Aza-Ven to oral Aza. I personally see how it can be feasible and acceptable, but I think that not all the physicians will be in agreement that it's giving the same chance to the patient. Oh, I don't know what's your perspective on that.
No, absolutely. We need a trial in the not in maintenance with oral azacitidine in all combinations, of course. So I don't have in mind such trials that are designed or ongoing, and this makes me pose a question of why, no? Because it's so evident that it needs to be purchased, no? This opportunity of a full oral induction, let's say, schedule for our patients. So we don't have all information on why not starting with oral azacitidine from the beginning, and we can have some responses maybe from myelodysplastic syndrome. As I remind, oral azacitidine in MDS as a front line to attempts to replace subcutaneous azacitidine were not very successful, as far as I remind. So maybe this is this is leading to avoid upfront oral azacitidine. So maybe the future will be to keep on induction, let's say induction with Ven-Aza as a classical Ven-Aza, and then switching to oral oral Aza and Ven maintenance. This could be a smart approach, but we need consistent data supporting this.
Well, guys, I think both of you've been absolutely wonderful. It's a fascinating topic. Obviously, we have more questions than answers, but this is why our field is really exciting. And the good news is that we have lived in AML with 3+7 and low dose RSE for more than 40 or 45 years. And now when we look over the last 5-6 years, we had so many drugs coming into the field. So hopefully the outcome of these patients with AML, because although it's relatively rare, median age is around 70 still, it remains a terrible disease, and only a small proportion of these patients are being cured. So all options are really needed and welcome. And the good news, I think, thanks to this trial we've been discussing today, that we have a new agent, this oral azacitidine, which is probably going to be a key player, but we need to continue to refine its use, and hopefully we'll see more and more exciting trials. So with this, I'd like to thank you all for your attention. You've been absolutely a lovely, wonderful audience from the beginning. Again, apologies, we had to start a few minutes late, but we had a few technical issues. Thanks to our superb faculty, and please stay tuned for more and more IACH activities. You should not forget that next week you have a post-ASH summary about transplantation made by Professor Nagler. So go for your free registration. Of course, we have our traditional monthly webinars, and do not forget the peer-reviewed journal of the IACH, Clinical Hematology International, soon on Prebet, and hopefully in Impact Factor. So we would love and welcome all of your submissions. But for the time being, wherever you are, please stay safe and keep well. Goodbye.
Bye-bye.
Bye.